All right. So thank you everyone for joining us today for the South Texas Regional Family Medicine Grand Rounds. Next slide, please. So here's the code for today. Actually, I think that code is different, Vivian. Hold on. Do you have the slide I sent you with the updates? If not, I'll just put the new code in the chat for everyone. Hold on one second. So the code should be 100962235 for today. So I'll leave that in the chat for a bit so you can all claim your credit. So this is just information regarding the AAFP credit system. Next slide, please. And these are the core competencies that the grand rounds will address. Next slide, please. And here's a brief introduction from Dr. Nato.
Thank you. So Dr. Vivian Nguyen is a UT Health San Antonio family medicine resident. She is a Texan from Dallas. She attended the University of Texas at Dallas for undergraduate studies and subsequently attended UT Southwestern for medical school. She is considering staying in Texas after graduation. She is going to discuss the use of antidepressants in chronic pain syndrome.
All right. Yes, so just thank you so much for the introduction. Just like what Dr. Nato said, I'll be covering the use of antidepressants in chronic pain syndrome. I have no financial relationships to disclose. I'm very grateful to be able to do this talk today, and really excited about, the things that we're going to be covering, especially because antidepressants are very commonly used for chronic pain syndromes, especially in older individuals. Let's see. Okay, so these are the objectives that we're going to be covering today. We're going to describe the proposed mechanisms of action of antidepressants in pain, discuss the efficacy of different classes and doses of antidepressants for chronic pain, and lastly, review the side effect profile of different classes of antidepressants. I specifically included the three pictures below because I wanted to emphasize different things in regards to chronic pain and the antidepressants that we use. On the very left-hand side, with all the circles, this is a picture that illustrates chronic pain and really the constellation of it. I wanted to emphasize that, there's different things that can be classified as chronic pain, such as fibromyalgia, chronic migraine, tension type headache, lower back pain, endometriosis, vulvodynia. And there's a great deal of overlap that can be seen with all these chronic pain syndromes. And at this point with chronic pain, it's considered to be neuropathic pain, which is distinguished from nociceptive pain, which is more of the acute pain. The second picture, it illustrates the different mechanisms of action of different antidepressants. So if you can imagine SSRIs, they inhibit the reuptake of serotonin. TCAs, the tricyclic antidepressants, also have a similar mechanism in inhibiting both serotonin reuptake and noradrenaline or norepinephrine reuptake. And SNRIs also have similar effects as well. The picture on the right-hand side, I wanted to illustrate that there's a lot of different types of antidepressants. I will say for chronic pain, there's two that's commonly used, TCAs and SNRIs, duloxetine specifically. But in talking about antidepressants and pain in general, it's important to consider the other antidepressants such as SSRIs, MOIAs. So that's a whole constellation of antidepressants to consider. So again, chronic pain syndrome, it's an overarching diagnostic classification. It can be used to describe various conditions, such as musculoskeletal pain, neuropathy, chronic headache. According to a study that was conducted by the NIH from 2019 to 2020, the incidence of chronic pain has been noted to be higher than that of the incidence of other chronic medical conditions, including diabetes, depression, and hypertension. So chronic pain has a huge burden in the US. In 2021, an estimated 21% of adults in the US experienced chronic pain, and an estimated 7% experience that to the fact that it substantially impacts their ability to do daily activities. Um, Chronic pain is addressed using a multimodal approach. There's a non-pharmacological treatment, which Dr. Rheiner will be addressing. For my talk, I'll be addressing some of the pharmacological treatment with antidepressants. The FDA, despite what we use for antidepressants, the FDA really only approved two antidepressants for chronic pain. Cymbalta is approved for diabetic peripheral neuropathy, fibromyalgia, musculoskeletal pain of a target and max dose of 60 milligrams per day. There's another medication, SNRI called Savella, that's only approved for fibromyalgia. I will say there's a lot of barriers to initiating and continuing this medication. Essentially, whenever you start this medication, you have to titrate it every 2 or 3 days for a week. So that's not really feasible for a lot of our patients. It is not indicated for depression or anxiety. And Public Citizen, one of the online petition websites, released a concern for its safety and limited efficacy. So it's not a very commonly used medication, but it is FDA approved in addition to Cymbalta. As of reveal of all the other antidepressants, there are no other antidepressants approved by the FDA for chronic pain or pain conditions. Despite this limited number, the National Institute for Health and Care Excellence does recommend antidepressants, which seems to be kind of a step away from what the FDA recommendations are. They state to consider antidepressant either amitriptyline, citalopram, duloxetine, fluoxetine, paroxetine, or sertraline for people aged 18 years or older to manage chronic primary pain after discussing the benefits and harms. And they also explain if an antidepressant is offered to manage chronic primary pain, explain that this is because these medications may help with quality of life, pain, sleep, and psychological distress, even if there's no diagnosis of depression. And interestingly, this NICE recommends against the use of other pharmacological medications such as gabapentinoids, opioids, and NSAIDs. So again, just given what the NICE is recommending, and just given the fact that antidepressants are so commonly used for chronic pain, I really wanted to explore the use and efficacy of these medications for chronic. Before I get into that, I wanted to touch on the mechanism of action. Just to preface, the bottom line is the physiology of pain modulation is altered at the level of the receptor and within a central nervous system in a chronic pain state. Chronic pain is thus distinguished from acute nociceptive pain in this regard because the physiology is changed. Animal studies, there's a number of animal studies that suggest that antidepressants can reduce pain in states of this altered physiology. And I'll just walk through the most commonly studied and found mechanisms for antidepressants. On the left-hand screen, it's a pretty busy picture, but essentially it's showing that there's two different types, again, neuropathic and acute pain. In the state of chronic pain, the function of the A2 adrenergic receptors is altered. So when there's an antidepressant, such as the SNRI, there will be an increased amount of norepinephrine given the decreased amount of reuptake. And that increased amount can increase the release of acetylcholine, which induces GABA release. And this in turn actually works in favor of reducing neuropathic pain. The picture on the right shows the locus coeruleus, which is commonly depicted as a blue dot in cartoons of brain anatomy. The locus coeruleus plays an important role in analgesic anesthesia. Antidepressants can improve the function of this part of our brain by regulating AMPA, MADA, as well as the alpha-2 adrenergic receptor activity, like I pointed out earlier. Serotonin, it does contribute to pain modulation, but it's deemed to be less important in pain modulation compared to the antidepressant effect on noradrenaline, norepinephrine. Essentially, the descending serotonergic pathways can either facilitate or decrease pain transmission. When antidepressants increase serotonin in the spinal cord, that can reduce neuropathic pain. There's also some evidence that dopamine can affect pain modulation. It's unclear why, but SNRIs can actually increase dopamine within the spinal cord as well as the ventral tegmental area and modulate pain response that way. I left a little note on the bottom, so I talked pretty extensively about SNRIs, but in terms of TCAs, again, they inhibit uptake of norepinephrine and serotonin, so they can theoretically modulate pain through the mechanisms that I described. Wellbutrin inhibits uptake of norepinephrine and dopamine and can reduce pain through these two mechanisms, the serotonergic descending pathways as well as the dopamine pathways as well. Okay. To get into the meat of the use and efficacy of antidepressants, I will be talking about an overview of systematic reviews. This article is titled Efficacy, Safety, and Tolerability of Antidepressants for Pain in Adults. My biggest question is which antidepressant classes are effective for chronic pain? This article that I'm about to present is pretty comprehensive, I will say, and I'm very impressed with the study. It was published in the BMJ in February 2023 from the University of Sydney. It looks at 26 systematic reviews from inception to February 2022. These reviews that were chosen for this overview span 156 unique research trials and in total involve over 25,000 participants. In addition to the data they collected from the systematic reviews, the authors of this article reanalyzed and synthesized some of the data provided from the reviews in instances where there was pooled data for different antidepressant classes and pooled data for pain and safety outcomes. So again, in addition to the data they gathered, they reanalyzed some of the data to evaluate pain outcomes by antidepressant class. The primary outcome of this article is measurements of pain across various pain measurement instruments, a lot of them being pain instruments from using a scale of 0 to 100 and dichotomous outcomes. The secondary outcome of the study is safety outcomes of the antidepressants. In addition to these outcomes, the study examined the methodological quality of the reviews. They reviewed the risk of bias and industry ties, and they also looked at the certainty of evidence of the reviews, such as evaluating the heterogeneity of the trial results and limitations in sample size, things of that nature that can contribute to the certainty of the evidence. Inclusion criteria for this article, essentially they included all different types of antidepressant classes, doses, and regimens that they can glean from the reviews. Network meta-analyses that provided direct comparisons between antidepressants and placebo were eligible. When there was overlap in review topics, the author selected reviews with more trials relevant to the clinical question, and they favored Cochrane reviews over non-Cochrane reviews, given that Cochrane reviews generally have a higher methodological quality. Exclusion criteria for the study, they did not include reviews including children or adolescents. They excluded reviews that did not report pain or safety outcome measures. So I will be presenting 3 tables that I thought were very pertinent to this study and kind of just walk through it one by one. Essentially, the systematic reviews that they included were published between 2011 to 2022. They included pain conditions of any type. I will say most of the pain conditions that were studied were chronic pain conditions. As you can see in the picture, they covered fibromyalgia, tension headache, neuropathic pain. Interestingly, they also covered postoperative pain, which includes acute as well as chronic postoperative pain. They also talked about aromatase inhibitor therapy-induced pain of breast cancer, which is deemed to be chronic pain. Burning mouth syndrome is chronic pain. Functional dyspepsia is chronic pain. So again, a lot of these pain conditions are chronic pain conditions, and that's relevant to our topic today. Many studies included in these systematic reviews evaluated SRIs, SNRIs, and TCAs, as you can see in the figure there. Pretty importantly, only 40% of the fields were prospectively registered. So that kind of hints to the fact that the studies may be prone to bias and may not be as high quality as we would like. 5 reviews, so only 20% of the reviews that were chosen were Cochrane reviews. In the large systematic reviews that they claimed, there was a significant percentage of trials that were deemed to have industry ties, which limits our interpretation. They classified trials with industry ties as trials that have funding from the industry, but no disclosure that the industry had no participation within the trial, if that makes sense. And just to highlight, I bolded 4 different systematic reviews with a high percentage of trials of industry ties. So if you can see, in one of the reviews, 14 out of the 30 included trials have industry ties, and that trial had 4,000 participants, excuse me. And then the next picture shows 9 out of 12 trials with a high amount of industry ties, and then 14 out of 15 for the next systematic review, and then 15 out of 15 reviews, or excuse me, 15 trials with 4,000 participants had that. And then if you look at all the other studies, I mean, they have a good number of participants, but the ones that I bolded with a high amount of industry ties, those had the highest concentration of participants. So if you can imagine, a lot of these studies and participants had, the study was essentially conducted with a large amount of industry ties. This next slide shows the studies that were deemed to have antidepressants that are either efficacious or not efficacious. So I kind of put one table on the top, one table on the bottom. The table on the top shows the antidepressants that were deemed to be efficacious for chronic pain or pain conditions. There's a moderate certainty of evidence that the SNRIs can reduce specifically back pain, fibromyalgia, and neuropathic pain. There's a low certainty of evidence that things like duloxetine, paroxetine, amitriptyline can treat chronic pain. Note that there's a mean difference of around 5 in terms of the effectiveness. And this is a 5-point difference in the pain severity from a scale of 0 to 100. So if you can imagine, the SNRIs reduced pain by 5%, considering the scale. And it also showed that there's a risk ratio of 1.4 for pain reduction of 50% in fibromyalgia specifically. Out of the studies that showed moderate certainty of evidence for SNRIs reducing pain, they used duloxetine, Savella, which is the milnacipran, venlafaxine, and desvenlafaxine. For the duloxetine, the dosages tended to be 60 to 120 milligrams for 12 weeks. For the Savella, it was 150 to 200 milligrams for 12 weeks. For the venlafaxine and desvenlafaxine, the dosages and the duration were variable. The next table shows antidepressants that are not effective. So there's a moderate certainty of evidence that TCAs are not effective for functional dyspepsia. The other studies had low certainty of evidence that the antidepressants were not efficacious for pain. This next table shows trials that were inconclusive. And this table, essentially they determined that the evidence was inconclusive based on the fact that there's a limited number of trials per pain condition or very low certainty of evidence. And out of all of the trials, there's a wide range of evidence that was inconclusive for SNRIs, SSRIs, TCAs, and atypical antidepressants such as mirtazapine. Among all the reviews in the article, I will point out 9 reviews had high methodological quality, 5 had low methodological quality, and 12 had critically low methodological quality. So that's only 40% of reviews that had high methodological quality. And I just wanted to again emphasize that 18 reviews had inconclusive evidence of the efficacy. So a lot of inconclusive evidence, a lot of industry ties. Okay. So essentially, again, just like what I said, there's a lot of industry ties, a lot of reviews of low to critically low methodological quality. The thing that we did claim is that there's a moderate certainty of evidence that SNRIs can reduce back pain, fibromyalgia, and neuropathic pain. I included a table here that I created just highlighting the data that does show moderate certainty of evidence and kind of just to stack up the industry ties and the methodological quality for back pain. There's 47% of trials of industry ties. For post-operative pain, there is no issues, but I will say it covers both acute and chronic. So that limits what we can interpret based off that. For fibromyalgia and SNRIs, the methodological quality of the reviews are low. And there was a significant number of industry ties of that one. And the same thing with neuropathic pain, critically low methodological quality of the review itself, and the trials had a large percentage of industry ties. For the information regarding the TCA that was shown to be not efficacious, the methodological quality of that review was low. Some of the strengths that I've identified, I will say, again, it's a very comprehensive overview. It utilizes multiple tools to evaluate the quality of the reviews and certainty of evidence. They included an adequate number of systematic reviews. I consider a strength that they had a narrow focus on the pain component of pain conditions, because if you can imagine, a lot of chronic pain conditions have other symptomatology. So it's really good that they were able to examine the pain score itself and have that granulation. The limitations of this overview, there's a limited number of trials on the specific pain conditions, so that affects what conclusions that we can draw. Another thing is, given the nature of the overview, we can't exclude trials by the year conducted, especially considering that TCAs were introduced in 1959 and SNRIs were introduced in 1993. Okay. So just considering the fact that the systematic review and overview doesn't give a lot of good information or information that we can confidently take, I wanted to re-examine other pharmacological treatments for chronic pain. Bottom line, there's a whole slew of different things that we can use. Gabapentin, Lyrica, NSAIDs. In some instances, um, amitriptyline, duloxetine are included in that as well. And these are per the different guidelines from different societies. One thing I really wanted to consider is not only pain itself, but really broadening the question, do these antidepressants that we use improve quality of life, functional status, other symptomatology? There is evidence that it does reduce symptomatology of within chronic pain syndrome. For example, amitriptyline has been shown to reduce IBS symptomatology, excuse me. Antidepressants can also improve physical function and quality of life as well. So, you know, despite what the overview, despite the limited evidence from the overview, I will say there's a broader approach that we can take in terms of the medications that we use and can employ, as well as the other things that are not commonly examined, such as quality of life and functional status, that are so important for our patients. Looking at the safety and tolerability, I specifically narrowed on what was found in this overview. There are adverse effects from both SNRIs and TCAs. I was not able to assess the granularity of it, mainly just the adverse effects, just given the broad range, the broad overview of the topic. I will say the data for the safety and tolerability in this overview was imprecise. There was pretty wide confidence intervals for some of the risk ratios, going up to 100 even. So that limits our interpretation of that data. And it's difficult to meaningfully ascertain the relationship between dose and duration, medication, and adverse effects. So I can't really confidently say that duloxetine for short term has less adverse effects than duloxetine, for example, for 12 weeks. Just to talk a little bit more about safety and tolerability of antidepressants, I looked at some other reviews. There was a recent article that was published 2 months ago, and essentially the bottom line is the appraisal of the benefits and harms of antidepressants is challenged by the small sample size, industry ties, and uncertain the high risk of bias. And that greatly mimics the overview that I just covered. And they specifically pointed out very pointedly the efficacy and safety of TCAs were varied in dose use, duration of treatment, pain conditions being examined, and comparators, hence leading to inconsistent findings for its efficacy between trials. This leads to a challenge when attempting to analyze the results to produce clinically applicable conclusions, which I think was very surprising to me because we commonly think that TCAs cause a lot of side effects, but just the fact that the trials are limited, what we can glean is limited as well. There's a very low certainty of evidence for safety outcomes for SNRIs. Another systematic review found low certainty of evidence for adverse events and serious adverse events in multiple classes of antidepressants. So, taking this all into consideration, I wanted to talk about the next steps that we can do and what we can take from this overview. I wanted to bring up again all the guidelines that were recommended for different pain conditions and specifically talk about combination therapy. Combination therapy is supplementing antidepressant with pregabalin or other similar classes of pain medicines. Using combination therapy can lead to improved pain control in participants who have insufficient pain control with monotherapy. There's one study that looked at titration. They hinted that there's a need to carefully titrate to the maximum tolerated dose of each pain medicine used. That study found that compared to monotherapy, greater pain reduction was seen after receiving combination therapy for 10 weeks. So, if you, my perception is if you don't find a lot of pain relief with an antidepressant, consider adding on Lyrica, consider adding on opioids or things like topical lidocaine, topical Voterin gel, NSAIDs, things like that. Really, just like pushing a car, employ all that you can to help with pain relief, and you may see a greater benefit than monotherapy alone. Um, next steps that I also wanted to talk about are predictive modeling. Essentially, consider comorbid depression as a predictor of pain, and consider treating both the pain and the depression and mood symptoms that can come with chronic pain. When you do consider measuring the pain outcomes 4 to 6 weeks. And this is per NICE guidelines. Also consider daily pain variations, taking a look at the pain trajectory, and looking over time, even over years, to see whether antidepressants work for pain when you do employ that. Okay, this is my last slide. Just to recap some of the things I talked about. Antidepressants have limited data efficacy and safety in chronic pain syndromes. Many trials specifically evaluated the use of duloxetine and TCAs in chronic pain. Despite the limitations found in the overview, there are NICE does recommend the use of antidepressants over other treatments for pain. Other guidelines recommend several medications as first-line or second-line options. For my clinical practice, I will be considering the comorbid psychiatric conditions, considering the monitoring of the long-term use of antidepressants to evaluate the pain trajectory, and considering employing multiple pharmacological as well as non-pharmacological therapies to reduce pain. These are my references, and that concludes my talk. Any
Thank you
questions?
very much. Thank you very much. I think we're going to let Gabe talk, and then we'll save questions for the end if we have some time there. So I'm going to introduce Gabe. He was born in San Antonio, raised in the Bernie area. He completed his undergraduate degree in biomedical sciences at Texas A&M in College Station. He returned to San Antonio for his medical school training at the UT Health Science Center, San Antonio, Lozano Long School of Medicine. Afterwards, he chose to stay in San Antonio and is currently finishing his final year of residency at the UT Health Science Center Family and Community Medicine residency. And he looks forward to taking care of fellow Texans after graduation. And so could we load his slides up, please?
Let me switch to sharing my screen. Should work. Able to see him?
Looks good.
Perfect.
Looks good.
So similar vein to Dr. Nguyen, as these go well together. Like Dr. Nato said, thank you for the introduction. My name is Gabriel Rheiner. I'm one of the PGY3s. I'll be talking through mindfulness-based stress reduction in a comparison in a non-inferiority trial to escitalopram for adults with anxiety disorder. Our objectives for my portion of our talk, we're going to review some of the ubiquity of psychiatric complaints in the primary care setting, We'll go through the AAFP's recommendations for the treatment of generalized anxiety disorder. Then we'll jump into the article itself and look at what they looked at and the utility of mindfulness-based stress reduction and their clinical applications. And then at the very end, we'll kind of reflect on changes that we might consider making in our practice versus things that we took away just in general from the article. To start, just psychiatric complaints in primary care. I think we're all pretty aware that these are very common whenever you're in our primary care setting. There's been a lot of publications that talk about the burden of psychiatric complaints in primary care, and a lot of publications that also talk about us being, the first point of contact for a lot of these conditions. It's difficult to get them in to see psychiatry necessarily, and so we are often the first person that they see when they have a psychiatric complaint. One of the articles, or a couple of the articles I found, referenced that this psychiatric complaint is often as high as 53 up to 65% at a visit whenever they come to see us. So there's, almost a 1 in 2, if not better, chance that when you see a patient, they're going to include a psychiatric complaint when they come to see you. And so it's a good thing that we spend some time to review some of these and go over what our current guidelines are and what the AAFP has to say about it, as well as kind of the up and coming research for it. And in addition, specific things that we often see, 16 to 20% for anxiety disorders, depression, we often can see 20 to 27%, depending on what studies you look at. If you include dysthymia, single versus recurrent depression, those numbers tend to go up. But again, pretty high, about a quarter of our visits. PTSD had a much wider range from what I could find, anywhere from 2 to 40%, but somewhere around 12 to 15% if you look in kind of the middle ranges for how often you're going to encounter that in one of our visits. Looking from the pediatric side, so this article was pretty dated, to be honest. It was a little bit harder to find how often we're seeing pediatric psychiatric complaints, but this article was from the late 90s, and it was showing that the rate at that point was 22%. Given, I think, the fact that I feel like we see more psychiatric complaints now and patients are more willing to bring them to us, I suspect this number would be higher. But again, I didn't really have an article to back that up, but just personal thought. Just to review what the AAFP has to say about generalized anxiety disorder, starting with the DSM-5 definition, just to recap, this is defined as an excessive worry that occurs on most days for at least 6 months and causes significant distress or impairment. They then further describe it as having to have at least 3 of the following 6 manifestations, which can be restlessness or feeling keyed up and on edge, fatigue, concentration difficulties, irritability, muscle tensions, or sleep disturbances. So at least 3 of those 6 physical findings. In addition, as we always talk about for DSM-5 criteria, they can't be explained by another condition within the DSM-5 categories or by a substance or by another medical condition. Oftentimes we wonder what those could be. If you have a patient that has generalized anxiety disorder or panic disorder, things to keep in mind that could be causing their anxiety or panic disorder and are medically related. Hyperthyroidism, it's always a good idea to check and make sure that they don't have any hyperthyroidism. Arrhythmias can actually lead to some anxiety and panic disorders. And then medication use or withdrawal. So often with things like albuterol, levothyroxine, in a similar vein, if they come off of it abruptly or are overusing it, that can lead to some anxiety. Antidepressants, if they're withdrawn too quickly, can lead to some rebound anxiety and depression. And then similarly, the anti-anxiolytics that we sometimes use, if the patient abruptly stops them or is overusing them, those can actually lead to some deleterious effects as well. I think most of us would agree with the last statement here, that these can often co-occur with other psychiatric disorders, including major depressive disorder, manic hypomanic disorders, and substance abuse disorders, which means that if you have a patient that does come in complaining of generalized anxiety, it's probably a good idea to be screening them for some of these other conditions. And I know in our clinic, at least, we do spend a good deal of time doing some screening across the board for a lot of these conditions. So, but if you do have someone that's coming in for anxiety, always a good idea to make sure that there's not another cause that's leading to it. As of June 22nd, 2023, the USPSTF now recommends screening for anxiety in adults 64 years and younger, including pregnant and postpartum patients. I bring this up because actually the AAFP article that I'll be talking about later, I don't think that recommendation had come out yet. And so the article is from 2022 from AAFP, and it does not have any screening guidelines because I think this came out a little bit after that article. So, but as of now, we are supposed to be screening patients for anxiety disorders. In most clinics, I believe ours included, the GAD-2 can be used as kind of your general screening tool, and that can be followed by the GAD-7 if that GAD-2 is positive. And our MAs in our clinic are able to administer those for us, and that's really helpful for just screening your patients, and then that way you know going into the visit if you have more that you need to discuss with them. AAFP, when they talk about treatment, really we talk about two main arms. I know Dr. Nguyen talked about this a little bit as well. We have our pharmacotherapy side and our psychotherapy side. So cognitive behavioral therapy continues to be the most effective and well-studied form of psychotherapy when we talk about generalized anxiety disorder. And I'll talk about the comparison trial here in just a little bit. It is still AAFP's top recommendation if you're going to be using a psychotherapy. In terms of pharmacologic interventions, as we've touched on a little bit, SSRIs and SNRIs remain our mainstay of treatment. AFP looked at some meta-analysis that compared a few different ones. I know we just spent some time talking about different options, but really the takeaway from AFP was that escitalopram, duloxetine, venlafaxine, and pregabalin all appear to be very effective and well tolerated for the treatment of generalized anxiety disorder. Just to hit on this again, benzodiazepines, while they are fast onset and can relieve symptoms, are not recommended still by the AAFP for treatment of anxiety disorder. There's still lots of concern around dependence on these medications, withdrawal, and the rebound anxiety that I kind of brought up earlier. So these are still drugs that we don't want to be using on a consistent basis for somebody that has generalized anxiety disorder. They also go on to point out that yoga and mindfulness meditation can improve anxiety symptoms, but high quality trials comparing alternative therapies to first line therapies are lacking. I quoted that portion because I think it hits home on kind of the article that I'm going to be talking about because there's just not very many articles that compare our mainstays of treatment to alternative therapies that are not cognitive behavioral therapy that we already have some pretty good data on. So our study looked at mindfulness-based stress reduction versus escitalopram in the treatment of anxiety disorders. Just to talk through kind of the study design, it was a randomized controlled trial with a non-inferiority design. It was single-blinded. The raters, so the people that were comparing the patient's anxiety before and after some of these treatments, they were blinded to what they were receiving, but the provider and the participant were unblinded for some fairly obvious reasons that I'll get to, but obviously it's kind of hard to hide if you're giving them a medication to take versus if they're participating in a mindfulness-based stress reduction exercise. Patients were recruited between June of 2018 and February of 2020, and I'll touch in a little bit on the impact that had with the COVID-19 pandemic. Outcomes were assessed by the blinded interviewer, like I mentioned, at baseline, 8 weeks, 12 weeks, and 24 weeks into the study. Of the 430 adults that they assessed for inclusion, 276 were recruited into the study. And then of note, this study was conducted mainly in the Northeast, in New York, Boston, and Washington, D.C., through a couple of large urban centers and hospitals in the area. Applicants were 18 to 75 years old. They had to have a current primary diagnosis of generalized anxiety disorder, social anxiety disorder, panic disorder, or agoraphobia. The biggest exclusion criteria that they really landed on were a lifetime bipolar disorder, psychotic disorders, or obsessive compulsive disorder. They also couldn't have ongoing anorexia or bulimia nervosa. They couldn't have PTSD disorder, and they couldn't have substance abuse disorder, as well as significant suicidal ideation or behavior at the time that the trial was being started. In addition, they could not have completed a mindfulness-based stress reduction activity in the past year, and they could not have daily ongoing meditation, which I thought was interesting. Psychiatric medications that were allowed during the trial, trazodone, but it had to be at 100 milligrams or less, zolpidem, azopiclone, and benzodiazepines if the patient was already at a stable dose 4 weeks prior to their initiation in the trial. I will touch on that one a little bit later. I think for me, most of those are not that big of a deal, but the benzodiazepines I did think was pretty interesting, but I'll touch on that more towards the end. Blinding, they used a computerized block randomization, and then while they were revealed to the research assistant who told our clinician, like I said earlier, the symptom treatments were blinded to the evaluator themselves. So the person that ended up scoring them for the anxiety didn't have a clue which one they were on, and those severities were based on a CGI-S score, which is a clinical global impression of severity. For the interventions, the mindfulness-based stress reduction, this was an 8-week protocol where the patients went in for weekly 2.5-hour-long classes, a day-long retreat class during the 5th or 6th week, and a 45-minute daily home practice exercise. These occurred kind of at community or clinic sites in the area, and the instructors were taught in numerous forms of mindfulness meditation. There's a few listed on here, but breath awareness, body scanning, mindful movement, and kind of the definitions of those, but really kind of trying to focus on breathing, focusing on different areas of the body and feeling how that area feels in the body, and then trying to do stretching and movement that bring awareness to the body, so similar to those body scans. For our pharmacologic group, escitalopram was initiated at 10 milligrams daily and increased to 20 milligrams daily at week 2 if the patient was tolerating it well. For adherence to our pharmacologic intervention, the patients were evaluated on pill count and the patient report to make sure that they were taking their medications as prescribed. For completion, they were considered to have completed the treatment if 6 weeks of the escitalopram was used, or 6 out of 9 of the mindfulness-based stress reduction, MBSR sessions were attended. At conclusion, they used per protocol analysis, followed by intention to treat if the patients did not complete the full protocol. So our final enrollments for the mindfulness-based stress reduction was 136, and our escitalopram participants landed at 140, so pretty even. Improvement was measured based on a reduction of the baseline symptom scores from that CGSI or CGIS to completion. So by completion, that score in our mindfulness-based stress reduction group had improved by about 1.35 points, and in the escitalopram group by about 1.43 points. The difference in these groups landed at negative 0.07 with a 95% confidence interval of negative 0.38 to 0.23 with a p-value of 0.65. So insignificant between the two groups. And I'll touch in a second. I've got some graphs that we'll go over. But the low end of those confidence intervals remained below their pre-described cutoff value for non-inferiority of 0.495, which they decided on before the trial began, which shows that in their study, at least, that these mindfulness-based stress reduction exercises were not inferior to using escitalopram for the treatment of anxiety. This is just the graph that they touched on comparing the two. So looking at the inferiority between the two, that top one refers to the per protocol sample, and then the bottom chart or the bottom line is referring to the intention to treat sample. And as you can see, neither one of them is crossing the non-inferiority margin that they had referred to at the beginning of the trial. And so this mindfulness-based stress reduction appears to be pretty effective, at least in comparison to escitalopram when we're trying to treat generalized anxiety disorder. Okay, a few things just to touch on critique-wise. So the study did show non-inferiority to escitalopram. The numbers, though, as you probably noticed, there were only about 300 participants total in the program. So a big portion of this, the writers talk about, they had to stop recruitment because of the COVID-19 pandemic. So they were actually hoping to recruit for a little bit longer and try to get more patients. But as you saw, it was cut off in February of 2020, right before the pandemic was announced officially in the United States. So they were not able to get quite as many participants as they would have wanted. And so, obviously that's going to lead to some limited power for this study. But still, I think the numbers they got were not bad, but I certainly would have liked to have seen more. I referred to this a little bit earlier. It's always great if we can blind everyone to the study, but I recognize that blinding everyone is kind of difficult to do whenever you're trying to use a medication versus like a mindfulness exercise. I don't exactly know how you would be able to blind someone to the mindfulness exercise, so I get where they're coming from, but again, having everyone be blinded would have been best. The benzodiazepine use I touched on a little earlier was probably the thing that was most concerning to me as I was reading the article, because I thought, how can we be effectively deciding if somebody on a benzodiazepine is really improving because of either the escitalopram or because of the mindfulness-based stress reduction. I felt a little bit better once we got to the end of the study. They mentioned that less than 5% of the participants that were included in the trial were using a stable dose of benzodiazepine. And so that did make me feel a little bit better about that portion. However, I still would have loved for that to have been an exclusion criteria too, because I think it muddies the results, especially for those patients that were using it. Of note, in the escitalopram group and in the BSR group, you can see there's actually a decent number of participants that didn't get through the entire treatment process. So 33 of the participants in the pharmacotherapy group and 34 participants in the MBSR group didn't actually end up finishing their entire treatment process. So like I said, they did use an intention to treat protocol for those patients, but it's a little bit disconcerting when you're already talking about a study that had pretty limited numbers to begin with, that really, almost a third of the patients that were enrolled in each group didn't end up making it to the end of the study. And so that always brings up a question, did we skew any results just because we didn't have enough patients complete? In addition, like I mentioned earlier, these are all studies that were completed in Boston, New York, and Washington, D.C. It's pretty far away from where we are. I think generalized anxiety disorder probably is decently well spread out across the country. But again, something to keep in mind, it's not exactly in the same area that we're at. And so there's different stressors that are faced up there, I'm sure, versus what we get here. And so it does probably limit it a little bit when you're trying to compare the prevalence of something like that in the Northeast versus down here in Texas. some of the things that I thought about too, factors that might prevent our patients from, participating in traditional CBT may also prevent them from participating in MBSR, if we're being honest. I have a lot of patients that talk about time, access to facility with trained professionals, how they perceive what we're trying to get them to do. There's not really any solutions that the article talked about for how you could really get around these problems. And I do think that they're worth mentioning. In addition, I'll kind of get into this when I talk about my own thoughts about the study, but based on what they talked about for some of these mindfulness-based stress reductions, it seems like there's a decent amount of overlap for what I would have considered to be CBT in the first place. And so I'd be curious to see, really what the difference would be between those two compared to each other, and how you could even really get someone to show up for MBSR if we already struggled sometimes to get them to participate in CBT. And then the biggest thing really is just that there's not a lot of studies for alternative therapies to our well-established CBT and pharmacotherapy options for generalized anxiety disorder. The authors of this study believe this to be the first time that it had ever been compared between non-CBT forms of mindfulness therapy and a pharmacologic option. So and this was a really recent study. So it'd be really good if we could get some other comparisons like AAFP talked about between things like yoga and our pharmacologic options. There's just not really been a lot of large-scale studies to try to compare the two options. So kind of bringing it home, what would I do if I were to look at this paper and try to figure out what I was doing in practice? To me, if I was in an area where we didn't have behavioral health counselors, and I'm grateful to our BHC team that we have in our clinic. But if I didn't have that, and I didn't have someone, therefore, that could really, get our patients to participate in cognitive behavioral therapy, but I somehow had someone that could do mindfulness-based stress reduction, I think it could be a treatment option. But again, kind of jumping into the second point, it seems to me like some of the stuff that they were doing for mindfulness-based stress reduction overlaps with some of the treatment ideas that we use for CBT and some of the mental exercises that we have our patients perform for CBT. And so I'm almost wondering if what they were considering MBSR really could just be considered an extension of what we do for CBT. But again, I think it'd probably be worth trying to study perhaps those two compared directly at each other to see if they're both effective. And then, the same problem would remain that if I was in a place that didn't have BHC, the likelihood of me having somebody that could properly do an MBSR exercise is probably pretty low. And again, you really run into the same problem that our patient's going to show up, or are they going to feel like they have the time and resources to get to some of these places if they're not available in your clinic, or they're just far away, or they just don't have the time because they have to work. I think at the end of the day, for me, this probably doesn't change how I would practice on a day-to-day basis. But I do think it really drives home the point that we always try to talk about with patients, that while our pharmacologic options are very effective at treating some of these conditions, the best thing we can be doing for them is also including non-pharmacologic options. That really the best way that they're going to get the most bang for their buck is if they're also participating in some form of CBT or mindfulness-based exercise to try to really treat these conditions. So I think, to me, if nothing else, that really just continues to drive home the point that we need to try to get them engaged in multiple ways of treating their condition. These are the references that I used for my presentation, and then I think that's it for me. So I think, Dr. Nato, you had mentioned we'll try and leave a minute, left a little bit of time for questions for either one.
Yeah, we have a few minutes for questions. So questions either for Dr. Rheiner or Dr. Nguyen? So I had a follow-up for, well, if nobody else does, I had a follow-up for Vivian. So just to make the point, you had the one graph right at the beginning where you had all the different kinds of chronic pains sort of lumped into a big pile. And I think that's good as a starting point to describe what studies you were doing. I thought it was interesting that you had headache pain, specifically migraine pain in there, because I think that's a type of chronic pain that actually is more amenable to treatment than some of the others. I think the success rate with that is quite good. So I think just to make the point, there's a wide variety of different pathophysiologies in that pile, and therefore your discussion talked about different therapies, but it's a very broad topic.
Yeah, we'll say the study that I used did not look at a lot of chronic headaches. A lot of it focused on neuropathic pain and fibromyalgia. And so I'll be interested to see, what the data for antidepressants and specifically chronic headaches are.
I think the studies validate the both talks validate some of the approach we have, where we combine the behavioral health approach with the other medical therapies that we have in the clinic, and so I really appreciate you guys taking that on.
Dr. Reiner, I don't know if I missed it, but the patients with anxiety, the cohort, did that include those with like panic attacks as well? Okay.
Yeah, they were considering anyone with generalized anxiety disorder, panic disorder. Let me pull it up again. But yes, it did include folks with panic disorder as well.
Perfect. Thank you. Oh, and sorry, another question to clarify. The MBSR, were those all in person? Is it like the sessions, the 9 sessions?
That was my understanding because so some of them were reduction exercises that they could do at home that were mindfulness-based ones they could do at home. But then there were also like instructor-led group sessions that they went to.
Gotcha. So the 6 out of the 9, that's like in-person sessions that they attended.
Any other questions? Well, thank you both for the great presentation, and I think we'll end it here and go on to the Teams meeting. I think it's next. Thanks.